February 25th. Afternoon House Healthcare, and today we have there's been a little confusion over one of the budget items that's in the governor's recommend around sort of bridge funding for Blueprint as the ACO winds down. So we thought we'd get Blueprint in to explain it to us and ask any questions that we may have. So thanks for joining us.
Thank you so much. With your permission, I'd like to share some slides so that we can kind of all start on the same page.
Sure.
Awesome. Thank you. Let me get those up. And here we go. All right, so I'm Addie Armstrong for the record, and I'm the Blueprint Health Services researcher. Our executive director could not be here today, so you got the data person. So hopefully I can explain things about the budget and the numbers and all the things that matter, at least for a while. I'm also here with Monica Ogilvy. She's on Zoom. She's our Medicaid policy director, and she will take policy-based questions which are beyond my scope. So I'd like to talk a little bit about the interim funding for Medicare contributions to the Blueprint for Health initiatives. And we'll get started and just kind of go over what this is and what these initiatives are so that we all have a ground zero for discussion. So Medicare payments towards Blueprint for Health. Medicare does make payments to different Blueprint for Health initiatives. It makes payments to a lot of other things as well, but we'll focus mostly on the Blueprint ones for now. Currently, it makes per member per month payments. We call those PMPM payments toward 2 Blueprint initiatives and a program called SASH, which I'll touch on a little bit more, that Blueprint does not administer. And this is allowed by the Centers for Medicare and Medicaid Services, the feds, because Vermont is part of an agreement with CMS to let Medicare make these kinds of non-standard payments into other things than just fee-for-service, which is traditional Medicaid. That agreement is coming to an end this year, so that will end December 31st of 2025, which means next year, due to all the rules and regulations, Medicare will not be allowed to make any of those payments. And that is the kind of start of what we were hearing about as this bridge funding that we'll touch on. So when or if a new agreement begins, Medicare will be back to making payments, and that's kind of why we're talking about just a small portion for a short period of time. So what is Medicare paying right now? If we start there, we'll understand what this is going to cover. So right now, Medicare makes payments to Blueprint Patient-Centered Medical Homes. That's one of the Blueprint initiatives. And these are value-based payments that go directly to the practice itself. So the doctor's office, your primary care practice, gets a payment based on how many Medicare patients they see, basically is the idea behind that. And these payments support practices to achieve National Committee for Quality Assurance, NCQA recognition. You might have heard the NCQA acronym being thrown around in various places. That's what it is. And that is recognition that basically kind of certifies that these practices are providing high quality care, that they're meeting all these data and reporting requirements, and they're, making an honest to goodness effort to deliver the best possible care to their patients. That payment is about $2.24 per Medicare member per month. Medicare sends that out. And it represents the Medicare portion. So these payments are actually made by all the insurers, Blue Cross Blue Shield, Cigna, MVP, Medicaid. But the Medicare portion represents about 25% of the total PCMH funding for that Blueprint initiative. So they pay about a quarter of that. That totals over the course of a whole year about $2.6 million.
The whole statewide.
Whole statewide, yes.
So can you, and well, I just want to clarify one thing. So the 2.6 is for one full year.
Yes. That'd be all of the calendar year.
Okay, not just bridge funding from December 31st of 25 to July 1st of 26.
It'd be the whole calendar year of 26.
Okay.
Yeah, and this is the whole calendar year of 25. That payment will be about 2.6 million.
Leslie, go ahead.
So I'm just looking at $2.24 a month, which sounds pretty trivial, and wondering I'm sure every practice is different, but can you give me an idea of an average amount of money that goes into a practice?
Not off the top of my head. That's a great question. But because the different practices have different numbers of Medicare patients,
Clearly.
you know, you might have one patient practice that sees like 100 Medicare patients. Okay, and gets $200 a month, right? You might have another that sees 10,000, and
Right.
that's less
I'm
trivial.
just trying to understand the impact and, of that.
Yeah. So typically, as we get on, I'll talk a little bit about the total number of Medicare patients. We see in Blueprint practice around 75 to 77,000 a year. So that's where a lot of that is coming from. Other questions on this guy? Second initiative of the blueprints that Medicare pays into is what we call the core community health team. So the core community health team is staff. It's people who provide services to Vermonters. And these staff provide unbillable care. They provide care coordination, special supports. They can be things like diabetes educators. These are things that, Medicare might not traditionally pay for, but through the community health team, Medicare patients can access those services without paying for them and without having a bill for them. About $2.80 per patient per month. That's the current number that Medicare is paying on these. And that represents about 30% of the funding that those core community health teams receive. So when we kind of go out and think about how many staff is that, we think that's about 30 full-time equivalent positions. Could be more, could be less. It's really hard to break it out because, like we were talking earlier, if someplace only has 100 Medicare patients, well, there's obviously not a whole position. But if they have 10,000, that's more. So we don't have an exact value for that, but it's around, they'd be supporting around 30% of the staff. And that totals in a year about 3.1 million. Again, that's a calendar year, same as the other. Questions on community health?
Why, if it's the same number of patients, why are they supporting 30% of the CHT and only 25% of the per member per month?
Fantastic question. You noticed a key. So one of the things here is that Medicaid PCMH payments are actually quite a bit higher. They're around $465 per member per month. So percentage-wise, Medicaid PCMH uses up a lot more, but Medicaid pays the same amount to community health teams as all the other insurers. So that's where that difference is coming in. And that 465 includes, that happened because Medicaid had another program lumped into the community health team. And so that raised that from $3 to $4. And so that's where that difference is. Yeah, good catch. Other questions? So that's, and the third thing that this funding supports is SASH, support and services at home. Again, this is not a Blueprint program, so I am not going to tell you all the details on it, but it partners with organizations all over the state, 70 different organizations, and supports 500 or more older Vermonters and people with disabilities to really live in their homes in the way they want to live. So that's an important program. SASH is managed by Cathedral Square. If you would like more details about SASH, Cathedral Square, I'm sure would be happy to come in here and give you a much better presentation than I could. That support, Medicare supports them with about $5 million a year, 5.1 last year. Yes.
And that's ending at the end of this year.
Yes. So all three of these are Medicare payments that are made because we have this agreement that closes at the end of 25.
Okay.
So SASH is part of the all-payer model?
The Medicare's ability to pay into it is,
Okay.
yes. SASH itself they have other funding sources. I'm not going to get into those because I don't know them all, but they do have and there are other things, but the kind of bulk of it there, that's part of this Medicare's ability to pay into these not standard, did I take your blood pressure services?
Leslie, did you have a?
What's bridge funding to what?
Okay, so let's move on to the next
Okay.
slide, and I will talk about this a little bit more. So this is, I call it interim funding because I think of it as in between two different organizations. And a lot of people are referring to it as bridge funding because they're saying it's bridging between the model that's going to end, the all-payer agreement that we currently have, which allows Medicare to make these strange payments, and a new agreement that we're hoping will start in 2027. And so this kind of spans that time period. So I think that's where that fitting.
What happens if that new model doesn't occur?
Great question. I am not the person to ask that of.
I think no one in this room knows that answer clearly, but I'm just saying the question.
Yes, I think it's a fantastic question. I can take that back to AHS and they can send someone who has more of a kind of 1,000-mile view than I do down to answer that question.
Thank you.
So the governor's budget, as you've invited me here to talk about, includes that $10.8 million, which if you added real quick in the margins is the 2.6 plus 3.1, 5.7 plus 5.1 is the 10.8. And so that is that funding to kind of provide interim funding while we set up a new agreement with Medicare so that Medicare can go back to providing that funding, which is the hope, I think, in the long run. Of that 10.8 million, it's not all state dollars. And that is something to really kind of wrap your head around. The first time I started looking at this, I was like, wait, what are you talking about? Why is there extra stuff? 4.5 million, 4.45 is state funding. That comes out of Global Commitment at the general fund. And the other 5.5 million will be paid with federal dollars, which match all of the dollars we put into the Global Commitment Fund. So about half of it is state dollars and about half of it is federal dollars that provide a match. And the amounts were estimated based on what I just went over, which is what they were paying in 2025 and using those values going forward.
Sorry, I hadn't been thinking about the federal match, but so basically Medicare is going to stop paying these payments because we're no longer part of an all-payer model, but we're going to pay them through Medicaid and they're going to do a match on it.
Essentially, that's what's happening, yes.
Okay.
We're still trying to get federal dollars to fill in some of the hole. It's basically the fundamental underlying scheme.
Okay. Any questions on that?
So one of the questions that was kind of posed is, what are some of the inclusions and exclusions? That 10.8 million line item is just those three things that we talked. It does not include anything. Things it does not include, other Blueprint initiatives. You heard a 101 on the Blueprint earlier this year that talked about spokes and pregnancy and pension and mental health initiatives and all sorts of things. None of that is included. It does not include comprehensive payment reform payments, and it does not include the ACO population health management payments. And both of those are not Blueprint related. So I'm not the best person to answer a ton of detailed questions about those, but those are just some of the things that this is not about. This is just about those three programs.
So I just want to confirm on the bullet payments for any other initiatives, like any other initiatives or just the expansion?
Any others. So Medicare never paid into, say, the Spoke initiative or the pregnancy and pension initiative, and it's not going to start, and that 10.8 million does not include anything to start paying into those.
But are we still doing those
We are
initiatives?
still doing those,
Okay.
yes. They are solely funded through other ways.
But we're not doing the expansion
Correct. There's no money in the budget.
Excuse me.
to continue with the
continue the
2-year
mental health.
pilot that we were doing.
Correct. There's nothing in the budget for that continuation.
And do we know how much that would be?
So I'm going to ask
Go on,
Monica. I think if she has that in front of her and she wants to say that, or if that's something we need to get back to you on.
I don't want to misspeak. For the record, this is Monica Ogilvy. I'm the state Medicaid director.
So Monica, do you know the dollar amount for the CHT expansion if we were to continue it?
I don't know it off the top of my head, but I'm going to look for it.
Thank you.
Thanks. So the other thing that we have all kind of heard throughout.
I'm going to go back because I didn't know if your slides were one that had additional bullets.
I don't have
But
additional bullets.
the presentation we actually have online, we have
another line under
It does,
HCO.
and it's moved to the next slide.
Okay,
Yes,
say, we're gonna talk about that?
yes, it's moved to the next slide.
Okay. Yes.
So OneCare Vermont is the largest ACO in the state, and it is closing in December, along with all of the alt Medicare kind of all payer model going away. There are a variety of things that OneCare does that I cannot talk about because OneCare and Blueprint are separate, but OneCare does administer the Blueprint payment. So those two payments we talked about are administered through OneCare, and that is one of the things. And there are a few other things that OneCare currently offers that we currently have not identified who's going to support those going forward. The population health management and payment reform payments that I mentioned on the last slide, the administration of the Medicare, PCMH, and core CHT payments. That's what so currently what happens is Medicare basically sends OneCare the big check, and then they do the distributing. And so as this changes to state funding, we will figure that out, and someone in the state will do the distributing of that. OneCare offers a lot of data analytics and quality improvement kind of programs to the practices that are part of it. And that is, I think, the bullet that I moved over to really what OneCare is offering. And we have not determined where that support would come from yet either. And then the other thing that OneCare offers at the moment is support for participating in the Medicare's merit-based incentive payment system called MIPS in casual conversation. And currently, because of the agreement that we have with CMS, practices in Vermont do not have to participate. They do not have to send all this data to CMS and have people evaluate them and then give them a score and decide how much they earn off that score. If they are big enough, and there are some rules, there are lots of rules, I don't know them all intimately, but if they are big enough, practices will have to participate in MIPS starting in 2026. Other ACOs in other states do offer support to their practices for that kind of reporting and submission and all the data stuff that goes along with that. We have not yet figured out exactly how that's going to work. Questions there?
I'm sorry, can you talk a little bit more about the population health management and payment reform payments?
I can. I'm not the best person to do that. So this is not something that the Blueprint covers, and probably the best thing for me to say is we should get someone else from AHS down here to tell you about those, because they're not Blueprint related. What happens is in the ACO level, there are other payments that are value-based or based on different incentives and things. And currently, OneCare is the administrator of those and kind of handles that shuffling around. That's what I know about it. We can take that back and get someone who knows way more to answer that question, unless Monica has any ideas.
Yeah, no, I was actually going to say, we knew that we anticipated the end of OneCare was coming. And so we've been working very closely with them to understand what it is. I mean, we know what they do that's incredibly unique and helpful to the state in this space. And so trying to think about how we can integrate some of that into what we do already, or what are the gaps that we're going to need to fill moving forward. So that analysis is underway. We're working really closely with them. And my recommendation might actually be that we could bring in OneCare and AHS together to talk about that, because OneCare's approach to this work is quite detailed and might be of great interest to understand what the gap might be remaining.
I understand that one of the gaps is, and maybe let me back up. I think one of the gaps are payments that are going from OneCare to providers outside of Blueprint. So we have the Blueprint, and then we have these other payments, which I think, as we talk about budget, is really important for us to understand. So is that one of these bullet points?
The population health management and payment reform payments.
Okay.
Yes.
And does AHS or anyone know how much that is on a yearly basis?
I'm going to turn to Monica for that one also.
Yeah, I hear a lot of questions about dollar amounts, and we can follow up with a memo with all the dollar amounts being requested, because I want to make sure we're giving you the right numbers.
So just so I think I'm understanding, so let me verbalize it in a not so clear way, and you tell me if I'm incorrect. So right now, Medicare pays the ACO for $2.6 million for the PMPM, $3.1 million for the CHT, $5.1 million for SASH. AHS pays into the ACO for other things. And with the ACO ending, AHS is not going to continue those other things. Basically, they're going to take that money and pay what Medicare was paying for these three items. Is AHS going to continue these things bridge funded? Or is that money now being used to make up for what Medicare was paying?
So the population health management and payment reform payments are not included in the budget. And that, because they're not Blueprint related, I'm not a great person to tell you where they came from and how they appeared and who pays the dollar amounts and where they go. I'm going to let Monica speak to that if she has more details, because she will know more than I will on that.
Monica, am I somewhere in the vicinity?
I think really what we're trying to identify here is, while we anticipated that we would be shifting from one all-payer model to the next all-payer model from year to year with no gap, we didn't anticipate or think that this would happen when we saw that our transition to the next all-payer model would likely leave a year between the two. The last thing we wanted to do was lose some of those essential services that had created traction and momentum and provide quite a substantial number of jobs, and to lose those for 1 year before the next all-payer model begins. And so this was our attempt to continue some critical services that we knew would be left without funding as a result of not having that infusion of Medicare dollars. So it's really just what did we anticipate Medicare would be contributing for 1 year in order to keep these services going, and what is that delta, and what do we need to fill that gap? And that's where that 10.8 comes from.
So the 10.8 though does not make the year whole based upon what the ACO was paying out for all programs. It only makes the Medicare, PMPM, CHT, and SASH whole.
That is correct. Yes, it's just filling that Medicare gap between all payer models.
And do we have any idea how much AHS will not be paying now towards all the things on this slide?
I will get all of the financials and send them to you in a memo.
Lori, I'm sorry.
I was just like, so we're doing budget this week, Monica, so hopefully we can get that tonight.
Yeah, we can work on that, no problem.
Thank you.
Yeah, we're discussing budget today and tomorrow morning. Leslie?
Just clarification for me, I'm sorry. So the 10.8 is not in the governor's?
It
It
is,
is, okay,
yes.
sorry.
There's a line item in the governor's budget that
I
says
just wanted
something
to
10.8.
clarify. Thank you.
That 10.8 is in the governor's budget. This stuff here for.
Yeah, the one care thing and that.
This is not. Okay. All right, thank you.
So now you got the data person. So I have to show you some fun graphs because that's who you ended up with. So what will this interim funding do? I like to kind of look at these two graphs. The first one here is how many Medicare patients are paid for each year. And this goes back to 2022. We do have to wait every year a couple months out of the next year before we can get numbers because there's the claims run out and all this stuff. So I don't have all the 23 data yet because we're waiting. But it's, as I said earlier, around 77,000 Vermonters receive these payments. And that's about 60% of Medicare patients with any primary care attribution reported in the claim system. Why is it only 60%? That's a great question. And I like to jump in front of it. When you get older, often you have a specialist for a variety of reasons. And sometimes people will be getting their primary care at a specialist's office in some way, or someone who identifies more as a specialist than they do as just a primary care physician. So that causes this kind of only 60% of people are visiting these kind of primary care practices. But that's still not a trivial number when you're talking about 77,000 people. So that's really what that 2.6 million number we talked about first is going to. Then my next slide is also fun for me. What about that impact on the community health teams? We already mentioned, that's 30% of the funding, maybe about 30 positions. 29%, and this is my latest number, it fluctuates a little bit from quarter to quarter, but last quarter, 29% of patients seen by the Blueprint community health teams had some form of Medicare. And that does include Medicare Advantage. It includes Medicare with a supplement that's provided by someone else. It's all some form of Medicare. When we were studying what CHTs do, we did a chart review. And in that chart review, we asked, how many encounters does the average patient have with a community health team when they're visiting the community health team? And that's about 3 per quarter. And so if we're looking at this graph, which shows the number of Medicare patients who visited community health teams, it goes from around 6,000 to around 9,000. So that means that is between 18,000 and 25,000 unique encounters, meaning actual visits. And when we count an encounter, we don't mean I called you and reminded you you had an appointment. We mean somebody did medication management with you. They maybe reconciled all the lists of medication you had after you got out of the ER. Maybe they sat down and you met with a dietitian and went over how to better control your diabetes, something like that. We mean an actual service provided when we say an encounter. So that 3.1 million is paying for between 70 and 100,000 visits and services provided to Vermonters in a year. And that's pretty significant. So I like to always end with this is why we want this money. This is what it's doing if we're talking about it.
I love that I get to editorial it. Every time Blueprint is in here, I'd like to remind people that the Blueprint serves everyone, but not everybody pays into it.
This is true.
Yeah. So I think we've been talking a little bit about failed funding models recently. And everybody benefits from a program that only certain payers pay into. Does anyone have any questions? If you could get, Monica, if you could get those numbers for us as soon as possible, it would be really great.
Sure, and I've been able to dig up a little bit of information. So if we have time to discuss further, I'd be happy to muddle it through the committee if that would be your preference.
Yeah, please, let's do that.
Thank you. So I heard questions specifically about funding gaps for 2026 as it relates to Blueprint for Health and Mental Health integration. Should we start there?
Sure.
Okay. So this was not funded in the governor's recommendation, but language is included in the House's version of BAA to amend the original pilot language to allow underspend appropriation to carry forward until expended. So we anticipate that we'll have some underspend, which should be able to carry us forward through calendar year 2026. It's unclear to me how much of the gap that will fill, but it should get us closer to 2027.
How much is that?
So the total gap amount in millions is 7.5. The gross DIVA funding secured is about 3 million. So the net remaining gap is 4.4 million, approximately.
Could you say that again? The remaining gap is what?
Sure. The net remaining gap is approximately 4.4 million.
So it's 7.5 a year. There will be anticipated 3 point, whatever number you said,
About
And-
3 million, yep,
which will leave a $4.4 million gap through FY 26.
correct.
And that,
But like
and
I said,
that's the
we do
mental
have,
health integration.
correct.
Okay. Leslie?
That's the pilot, sorry.
Yeah, that's the pilot that's in. Okay.
Correct.
I'm just curious if I may, Monica, to ask, is AHS supporting this? Like, what's your position on filling these gaps?
Yes, AHS is supporting it. I want to put a flagpole in the question that you asked earlier, which was a really good one about what are we bridging to? And I think at this moment in time, we are planning and bridging to an all-payer model that is going to start in 2027. And that is what we were planning and preparing for. Because to not plan and prepare for that would be really short-sighted. If for some reason there is not an all-payer model in our future, we will have to reckon with that. But this way we have the opportunity to have a comprehensive runway and more time to plan for that appropriately. To me, the risk of doing that versus a huge gap in service and funding between two models is far more detrimental from a continuity and momentum perspective.
Thank you. Thanks. Any
Thank you
other,
for the hard question. I think we're all dealing with quite a bit of uncertainty.
Yes.
any other payments that we're losing through?
This is more specific to OneCare and the change in OneCare. So you may have heard of comprehensive payment reform or CPR bridge funds. 1.5 million general fund. One-time funding was requested for state fiscal year 26 for 6 months of payments. That would have carried us from January to June. The funding was not included in the governor's recommended report. So let's see. However, 2.1 million approximately has always been DVA funded and remains in the DVA base budget. Trying to make sure I'm interpreting finance notes in a way that will make sense to myself and the committee. So thank you for your patience. So it does seem like the net remaining gap amount there would be 1.6 million.
Can you remind us what those payments are for? Comprehensive payment reform, what's the intent of those?
Sure. I'm wondering if my colleague Sarah is on. And able to answer that question more thoroughly than I am.
Hi there, this is Sarah Rosenblum. I'm the Deputy Director of Healthcare Reform at the Agency for Human Services. For the record, I would defer to OneCare Vermont. So for comprehensive payment reform, which Monica just spoke to, and then for the population health management payments, those are both OneCare Vermont buckets of funds. And I would, if the committee is interested in learning more about, I don't want to shortchange it. And those are OneCare programs. So I would defer to OneCare Vermont for those, for a comprehensive description of both of those.
Can you repeat those numbers? Oh, sorry.
Where do they get the money from to?
Those are paid through
Hospitals?
hospital dues.
Okay. Okay,
into One Care, which, so there's complexity here in how that money goes in, gets judged, comes back out.
okay.
So hospitals won't be paying those dues into this accountable care model for those dollars to be turned around and redistributed to practices. So that will leave a gap.
Leslie?
I'm confused about the actual numbers. If it's at 1.5 general fund, not in the governor's recommend, but 2.1 in the DEVA base budget, but then the gap was 1.5 million, but that didn't add up, so I messed up. Just trying to understand.
No, I appreciate the questions and I'm happy to take the time to walk through this together. And if you don't get the clarity you need as a committee, we'll follow up later this afternoon. I'll commit to making sure that happens. So the total gap amount for CPR payments, this comprehensive payment reform, is 3.78 million.
Can you stop right there? I'm sorry.
No, please.
We just, like, I'm with Leslie. I'm really confused.
Yeah.
So can we not use acronyms? And can we say if it's Blueprint or One Care you're talking about, please?
This is One Care,
Okay.
comprehensive payment reform bridge funds. Total gap amount is 3.78 million.
For the year of 2020, for what year?
Year of 2026.
Okay, thank you.
Of course.
And then you mentioned 2.1 in the DEVA base budget.
So
Okay, and that left
2.1
1.5. Okay, I see my mistake. Thank you. Much better.
Please.
Monica, this is nothing, this is just confusing, right?
Yes.
I had heard numbers in the hallways of like $10 million. So that's what I'm confused about. So I'm gonna put Blueprint aside, like I think we have that, the governor recommended the 10.8 or whatever it is. But there's these other payments that One Care does through hospital payments that are gonna go away on January 1st. That I think is going to leave a big hole in providers, especially independent providers. So that's the number that I think we need to get to, and I'm not that concerns me that it's 3.8 just the state fund? Well, no, it's not state funds, it's hospitals.
Hospitals.
So is the $10 million a rumor?
No, I think the $10 million is not a rumor. Really, so we've got, I'm going to back up for just a minute and put it in I know you all are immersed in this information. So we've got the gap that the Medicare contributions to Blueprint are going to leave is in the tune of $10.8 million. That's what we're trying to reconcile with. Then there is also the going away of One Care, our accountable care organization. That will also leave a funding gap to our primary care providers and to those that were getting those payments distributed. Two separate gaps as a result. One is One Care going away. That's going to go away no matter what.
Right.
One is a gap that we anticipate to be 1 year between all payer models.
So
And
it's
so we're trying to talk about that 1 year that we're concerned about in the middle between our all payer models, while the One Care impact is real, and we're happy to talk about that. That's going away and that's ending. We can talk about. Well, I'll just pause there and just leave that.
So that's going away completely, correct?
Correct.
Okay, that's a really good clarification for people that it's not just a 1 year gap. So the 10.8 or whatever it is for Blueprint, that's a fill a gap. And then you have these other payments with One Care going away. So it would still be great, and maybe it's not you all, but it would still be great to know what that yearly figure is that providers were getting from One Care.
I can give you the second dollar amount. So we talked about the comprehensive payment bridge funds. That was that 3.78 million that we just discussed. The second gap being left through the ending of One Care is related to their population health management payments. The total gap there, we anticipate to be $14.6 million.
And where does their current funding for that come from?
This is currently funded via hospital dues and payer contributions into OneCare, into the into the Accountable Care Organization.
As
Okay.
well as payments that come through DIVA.
How much comes through DIVA?
$4.8 million comes through DIVA. So if you take away that 4.8 from the 14.6, we would be left with a net remaining gap of $9.36 million.
So is DIVA filling 4.8 million? I think you said, I'm sorry, the numbers are flying.
Got it. Nope, that was correct, Chair.
4.8 is DIVA,
We never have no clue.
what is DIVA doing with that 4.8 million that they were funding that they're not because it's totally going away? Where's that money?
It remains in DIVA's base budget. I cannot speak to what exactly the 4.8 is allocated for at this moment.
So it would probably just be utilization and
I will say, we can follow up on this, but I will say that I believe those dollar amounts are still in DIVA's base budget and still for the intended purpose. When OneCare Vermont goes away, we will lose the mechanism to distribute those funds. And between now and 1/1/26, the hope is that we identify an alternative mechanism to distribute those funds. But the payments, those funding amounts themselves in DIVA's base budget, I believe the intention is for them to remain for their budgeted purpose. We're struggling not with from the DIVA perspective, the funding is still secured. It's the logistics of disseminating those funds that is a remaining question, given the closure of OneCare Vermont at the end of this year.
so they were for population health, but you don't know how you're going to distribute them, but you're going to use them for population health? Well, how can you
Yeah,
use
so
them for
there's
that
a
if you
ma-
don't know how to distribute them?
That's part of it. You know, there's a gap in the mechanics and the operations that's being left by OneCare going away. We have worked very closely with them to build analytics models and technical operation details to get dollars out the door into practices. And so those are details that we are in the process of assessing and addressing in terms of what that's going to look like going forward in the context of a new all-parent model.
Does Medicaid still pay the per member per month, which was separate from the ACO? Like I know that years ago, they used to pay a monthly per member per month. At one point it was like $5 and then those went to medical homes.
That's our Blueprint for Health community health team mechanism that you're describing. And there are a few different payment methodologies in which we reimburse a per member per month, but I believe in the context of this conversation, that's what you're talking about here.
Thought it was separate from the Blueprint one, but I must be mistaken. Daisy, did you have a question?
No, I think you're gonna send us something in writing that sort of details out what the gaps are, correct?
We can. It will be essentially what I just shared here verbally, and we'd be happy to put that in written form if it's easier for some people to digest that information. It would be for me, I know.
It would be great if you could do that, and I know Lori noted that we have to get our budget done by end of the day Wednesday, so as soon as you can, that would be super helpful.
Understood. Happy to work on that after this.
Thank you so much.
Of course.
All right.
All right, so of course, we're getting emails from those affected.
Yes.
And I believe, and I apologize because I don't think I was in committee on this day, but when Vermont Medical Society came in her budget testimony, she did provide the numbers that would impact VMS. And then we also just received information on the impact to the independents. So I can send this all to the group as well. But I'm still having trouble squaring that with what we're hearing here.
Leslie?
So I'm thinking about the hospital dues portion, to pay into nothing, or how do you imagine that unfolding?
I think that's still to be determined.
What's the process?
Right now, we're working very closely with OneCare to understand their mechanisms and how they're doing their work and what the gaps are going to be left, both from a financial but also an operational standpoint and data analytics. They've been quite a data analytic engine for us. And so we're trying to figure out what of that we can absorb into DVA, into AHS, and what we're going to need to outsource and how we'll outsource that. Again, some of that hinges on what the next all-payer model looks like. So we want to make sure that we are being thoughtful in what we're identifying as needs, so that whatever we're building is going to help sustain us moving forward.
Yeah, but I'm thinking about the gap year. I mean, are you going to charge them dues for the gap year?
I don't believe that that is our plan. We wouldn't have a mechanism to take those funds in and to redistribute them, but certainly I can connect with our colleagues and, but like I said, we know that OneCare has an end date, and much of what they're doing specific to those operations will end at that time too.
Thank you. Any other questions? All right. Well, that cleared everything up. I'm sorry. I shouldn't be. I shouldn't be sarcastic. It's really hard to understand. I hope you can appreciate that. Thank you.
Absolutely. We certainly do appreciate that. And we appreciate your questions and helping try to make sense of this incredibly complex information, especially in the face of a transition year and an incredible amount of unknowing at the federal level, which could have impacts that we're really still uncertain of. So our intention here is to build as much stability as we can based on what we do feel confident the future will look like. And we will continue to check in and adjust because that's our job.
Thank you.
Of course. Thank you.
I think we're gonna take a break. We're gonna take a break until 2. So we can go off of live.